to talk about a very serious subject indeed. This is called as retinopathy of prematurity. And this is a very serious thing because first it is complicated to understand, complicated to reproduce answers, and unfortunately it is so common that it can be construed as the second commonest cause of blindness in children after vitamin A deficiency. Can you remember? In developed countries, at least in advanced countries, after vitamin A deficiency, it happens to be the second commonest cause of blindness in children. But what exactly is it? So let's take a look. Retinopathy prematurity, as can be made out, is a vascular proliferative disorder affecting premature infants undergoing oxygen therapy. Now let's take a look at that. What is that? So there, as you can make out from the title itself, they're premature infants and they need oxygen, supplemental oxygen to survive. It's a vascular proliferative disorder. That means that the blood vessels of the retina proliferate in response to the oxygen that these poor kids are exposed to. And approximately 60% of high-risk babies develop ROP. Now, that's a very high figure, though this is a very approximate figure, but just to tell you, so we have some idea that approximately 60% of high-risk babies, not all babies, remember, develop ROP. Very well. But before we discuss all this, we go into actual ROP, we need to clarify our concepts by a few definitions, and let's look at that. A quick summary of what is a full-term child. And a full-term baby, for those who have not revised their obs and gynae, is defined as a child born between 39 weeks and 40 weeks and 6 days, to give it its correct definition. A child born between 39 weeks to 40 weeks and 6 days is a full-term child. And a preterm would be a child who's born less than 37 weeks of pregnancy. Okay, so less than 37 weeks, we call it preterm. Then a very important term called the gestational age, or the GA. Gestational age is the time elapsed between the first day of the last menstrual period and the day of delivery, is it not? And conventionally expressed as completed weeks. These are definitions which you have to remember. The first day of LMP and the date of delivery is gestational age. Second is chronological age, CA. Chronological age, which is the time elapsed after birth. So whatever the child's age is right now is called CA. And one more to add to the confusion is PMA, or post-menstrual age, which is the addition of gestational age plus chronological age. So when you add together gestational age plus chronological age, we call it the post-menstrual age, PMA. Okay? I know you are all familiar with these, but just to revise for those of our friends who are not too good at obs and gynae. Very well. And this is ROP, retinopathy. When you look at that horrible sight, you can see the grayish color where the retina has detached. You all know that the grayish glow of retina means retina is detached. Look at the tortuous vessels, dilated veins. There's angry retina, hurt retina. This is ROP. But what are the risk factors of ROP? So this is a child, the first and foremost is a premature child, born less than 30 weeks. Remember, preterm is less than 37. So this is a child is very high preterm, is it not? He is very majorly preterm, less than 30 weeks of gestational age. Another very important risk factor is the birth weight. This poor child is less than 1500 grams of birth weight. You all remember that in our country, which is India, the average birth weight of a child is 2.8 kgs or 2800 grams. This poor fellow is almost half the weight of an average child, which is less than 1500 grams. Okay, so these are very serious figures. You have to memorize them. On top of that, he is unfortunate enough, on top of that, he has to be given supplemental oxygen. These three factors are the major risk factors of ROP. There are others also, but these are the ones that we want you to memorize. So please remember, for your summary, it's the smallest, the sickest, and the most premature baby who has the highest risk for developing ROP. Again, the smallest, less than 1500 grams, the sickest, and the most premature baby, less than 30 weeks, I beg your pardon. Very well. So now we've got risk factors, and let's look at the oxygen dilemma. The oxygen dilemma is how much oxygen to give and how much not to give, because it is the oxygen which is basically responsible for the ROP. We all know that for a full-term healthy baby, every pediatrician knows that we can give oxygen. Almost 95 to 100% of saturation can be given to a full-term healthy baby. But this is not true for a preterm baby. For a preterm baby, various studies have shown, and these studies keep on changing, so our figures also keep on changing, but the latest studies show that the safe preterm babies, for a safe target SpO2 for a baby, should be between 90 to 94% oxygen. More than 94% would lead to high chance of ROP, less than 90% may lead to death. So kindly remember, this is our target SpO2 for a preterm baby. This can be asked and has been asked in MCQs. Very well. So let's look at the pathology. What exactly causes ROP? And for that, we need to draw this. Let's go back to my diagrams and see. Basically, this is a term baby, let's say. Okay, so this is a full term child. And what happens that the retina develops vascularization. It starts from the optic disc and goes towards the periphery. So this is how the retinal vessels develop. They start from the optic disc and they go to the periphery. So when you look at a full term normal child, you will see the retina has reached the vascularization has reached the retina completely. But this is a preterm baby and he is born much earlier, and in this case the blood vessels have started from the optic disc, but they have not had time to reach the periphery. They have not had time to reach the periphery before the child was born because he was premature. So when the child is born, there is a peripheral area of the retina which is not vascular or avascular retina. Avascular retina. And now see what has happened. What happens when the child is born is, remember, he comes out from his privileged position in the uterus where he is the king, and now he comes into the world to meet a cold, hostile world where every situation seems to be against him. As he comes out into the real world, he meets two sources of oxygen. One is the high concentration of oxygen, the room ambient oxygen. Second is the supplemental oxygen that he is given when he is born and sent to the ICU. Okay, so one is the normal high concentration of oxygen of the atmosphere, and second is supplemental oxygen. So now from a child who was in the uterus who had hypoxia, who had less oxygen in the uterus, now he meets two sources of high oxygen, and you know that the excessive oxygen, what it causes the basic physiological response to excessive oxygen is vasoconstriction. The blood vessels constrict. From physiology, you might remember that excessive oxygen causes vasoconstriction. So blood vessels constrict. As they constrict, they may cause vasoocclusion, obliteration of vessels. The blood vessels get obliterated, they get occluded, and paradoxically leads to hypoxia. So the hyperoxia, remember, excessive oxygen here, when the child comes out in the real world, he has actually hyperoxia, which is excessive oxygen. And paradoxically, this hyperoxia causes vasoconstriction, leads to vasoobliteration, and leads to hypoxia. And hypoxia, we all remember, produces VEGF, vascular endothelial growth factor, and this VEGF causes neovascularization. So this child lands up with new blood vessels which sprout at the junction of the vascular and the avascular retina. So paradoxically, this child now develops new blood vessels which come up at the junction of the vascular and the avascular retina. Let me see if this is quite clear to you, otherwise I'll just repeat this. So see what is what happened. Child is premature, and because he's premature, this is incomplete retinal vascularization. So when he comes out in the real world, he has hyperoxia, excessive oxygen. Hyperoxia, remember, is the basic stimulus. Kindly remember, for ROP, it is the hyperoxia which leads to ROP. It is not the hypoxia. Kindly remember, this is the basic stimulus. So you might get confused in the exam. It is the hyperoxia which is the culprit. Okay. So hyperoxia causes vasoconstriction, which leads to vasoobliteration. The blood vessels get obliterated. So you have lack of oxygen. That's hypoxia. So hypoxia has led to hypoxia. Hypoxia leads to VEGF formation, vascular endothelial growth factor, which cause neovascularization, as these new blood vessels have fibrovascular proliferation, and this leads to tractional retinal detachment. As the blood vessels proliferate, they pull the retina off, and the child develops a tractional retinal detachment. So this is the basic pathology of ROP, that the child loses vision, remember, not because of ROP, but because of tractional retinal detachment, which is the major cause of loss of vision. So kindly remember, the loss of vision can be tractional retinal detachment, which is most often the cause, But you can have a vitreous hemorrhage, which may also cause loss of vision, and it may cause macular dragging. The new blood vessels can drag the macula off, causing loss of vision also. So, these are the three major causes of loss of vision in ROP, but the first is the most important. So, this is the basic pathology. Now, we've understood it, and now we would like to see how to screen the child, and when to screen the child. Here there is a dichotomy, because one is given by the American Academy of Ophthalmology combined with the American Academy of Pediatrics, and one is the Indian guidelines. There's a slight difference because, as you know, the health of the Indian kids is not as robust as that of the Americans. So let's look at the differences. You should know both. American Academy recommends that children born less than 30 weeks of gestational age, should all be screened. But in India, we recommend that children born less than 34 weeks should all be screened. Okay, but as I said, these children are usually more sick in our country. So even children who are relatively less premature, let's say, can have ROP in India. So we would prefer to check it less than 34 weeks. These are the children who should be subject to ROP screening. Then American Academy, as I mentioned, less than 1500 grams of birth weight should be subject to screening. But in India, we recommend any child less than 2000 grams or 2 kgs should have an ROP screening. Okay, so these are different figures here. You should remember both. When should we examine the retina? When should I examine? Remember, it is not at birth, because this is not a congenital disorder. The child is not born with the ROP. The child develops ROP over a small time, so it is not at birth. And here, the two schools, they agree on the same figure. Luckily for us, mercifully, they have the same figure, which states that the initial screening, the first screening, should be 4 weeks after delivery. This is true for both India as well as worldwide. They should be screened after delivery, 4 weeks after delivery, or 31 weeks post menstrual age, whichever is later. So we should examine them at 4 weeks after birth, not before that. Why not? Because it's too early and you will not detect the ROP, you will be missing it. And usually not after 6 weeks, because after 6 weeks it becomes difficult to handle. So this is the initial screening where you must start and pick up the ROP. Before that or after that is counterproductive. So for both, this is correct, for 4 weeks after delivery or 31 weeks post menstrual age, whichever is later, which means gestational age plus chronological age, whichever is later. So this figure is same for both of them. So we start screening at this time. Very well. Now we classify ROP, and this is an important classification. I want you to remember this. We divide them in 5 stages. They are not so difficult. You can memorize it. And stage 1 is called the demarcation line. See the line coming up here, separating the avascular from the vascular retina. As soon as the line comes, you know that the patient is developing ROP, stage 1. In stage 2, the line develops into a ridge. Remember, line is a flat structure, two-dimensional structure, but as the blood vessels pull the line, so it gets elevated, this is called ridge. Stage 2 is ridge. Just remember the word ridge. It's a line with elevation as a result of the growth of the vessels as it starts pulling the retina towards the vitreous. Is it not? So this is first is line, second is ridge as it becomes elevated. Stage 3 is ridge with fibrovascular proliferation. Now you see the ridge is there, but now you can see the blood vessels also. They are pulling the retina off like this. Okay. Previously in stage 2, you could not see the vessels there because they are not yet appeared. They were there, but they are not yet appeared. But in the stage 3, you can see the ridge with fibrovascular proliferation. Okay. Stage 4 is subtotal retinal detachment, which means partial detachment of the retina, and stage 5 is total retinal detachment, when the retina is completely detached. As you can see here, the grayish glow tells you that you have retinal detachment. So this is not such a difficult classification. To summarize this, let's go back over it once more, and you can see this. It's quite easy, quite systematic. In fact, stage 1 is line, stage 2 is ridge when it gets lifted, stage 3 is ridge with fibrovascular proliferation or new blood vessels, stage 4 is subtotal retinal detachment, and stage 5 is total retinal detachment. Okay, so that's not so difficult. This is the stages of ROP. Very well, but more is to come. More is to come actually, and let's look at the primer. I'm going to prime you with some terms of ROP which you should know. And first of all, we divide the retina into 3 zones. Zone 1, Zone 2, Zone 3. and they're all centered on the optic disc. So we take the center of the optic disc as the center of the circle and draw our zones. Zone 2 and zone 3, it looks like this. So take a look at that. Zone 1 is the most posterior, the most central zone. What we do, we draw a circle with the radius. We take the distance from the center of the optic disc to the macula, the fovea, and we double the distance. Okay, the distance between the center of the optic disc and the fovea, we double this distance and draw a circle. This is zone 1. Okay, and zone 2 is a circle concentric to zone 1, but now the diameter or the radius of the circle is the distance from the center of the disc to the nasal ora serrata. So we draw zone 2, which is concentric to zone 1, and whatever little temporal crescent of the retina is left behind is called as zone 3. So zone 1 is center, zone 2 is mid-peripheral, and zone 3 is peripheral. Now, as you can make out here, the zone 1 is the most dangerous because this is where the location of the fovea and the optic disc. So as the blood vessels, remember ROP starts from the periphery, so as they encroach from zone 3 to zone 2, it becomes dangerous till they reach zone 1, which is the most dangerous because the advancing blood vessels can pull the fovea off. Okay, so zone 1, whenever blood vessels are in zone 1 or whenever ROP is approaching zone 1, tells us that we must hurry up now. Okay, so zone 1 is the most dangerous, followed by zone 2, and zone 3 is relatively peaceful. So this is the zone 3 zones that we define. So we now know our classification, stage 1 to 5, we know our zones now. The next thing is a term called plus, is very important. Plus disease, because we write the word plus. So we have a stage 3 and we write plus. If it's plus disease, we write stage 3 plus or 2 plus or whatever. And what is that? The definition you must remember is venous dilatation and arterial tortuosity, both of them, not one, but both. So veins get dilated, they becomes expanded, and arterial tortuosity means that they're very corkscrew-like. Look at the tortuosity. So the blood vessels, there are two types of vessels. The veins get dilated, and the arteries, they get tortuous, corkscrew-like thing. So they should represent at least 2 quadrants. Okay, more than that is okay, but less than that is not okay. So kindly remember the definition of plus disease: dilation of veins and arterial tortuosity present in at least 2 quadrants. This is a very serious condition because plus disease is a highly aggressive form of ROP, which means that the child is in deep trouble. Very well. So now we've got certain, but this is not the end. No, not at all. Let's look at the other definitions coming up now. Next one is called pre-plus disease. See, these definitions came up as more and more studies came up, and pre-plus, as you can make, is the stage just before plus, and that you can work out easily, is venous dilatation and arterial tortuosity, again, which is more than normal but less than that of plus disease. This makes sense, is it not? Pre-plus. So it is not as much as plus, but is not as less as normal. So whenever we get angry looking vessels where the veins are dilated and the arteries are tortuous, which is more than normal and less than plus, we call it pre-plus. Now one more definition we need to know, which is highly dangerous. This is called APROP, APROP for short, or APROP. It's called aggressive, stands for aggressive posterior ROP. Okay, aggressive. So look at the word. Aggression tells us what is going to happen, and it's posterior ROP. So it's right in this zone 1. So it's uncommon. It's not that common, luckily. It's uncommon, but it's a rapidly progressing severe form of ROP, often called rush disease. It's rushing through. Okay, it's so dangerous. Rushing through is often called rush disease. It's posterior location. So I told you zone 1 or zone 2. That's why it's called APROP, posterior. And it's increased dilation and tortuosity, again, like plus, increased dilation and tortuosity of vessels in all quadrants, out of proportion to disease, and the incidence rate is only about 2.5%, which is lucky for us, and it may skip through the traditional ROP stages. It requires immediate treatment. Okay, so kindly remember what is aggressive posterior ROP. So it's aggressive and it is posterior. So again, it's called rush disease. It's uncommon, only 2.5% of cases land up with it. It's a rapidly progressing severe form of ROP called rush disease. Its posterior location, zone 1 and 2, increased tortuosity and venous dilatation of vessels in all quadrants out of proportion to what is expected, and it may skip through traditional ROP 4 stages, 5 stages, and requires immediate treatment. So this is you can see the aggressive, you can look at the blood vessels, how angry looking they are, and this is a typical APROP, which can lead to very, very fast deterioration. Very well. So we've got our definitions now. Now, What about a natural history? Natural history means what would happen to us if we did not intervene. Now, luckily for us, remember, almost 85% of ROPs regress. Almost 85% regress spontaneously, which is lucky for us. Now, of the 15% left, 90% of babies develop a form of mild or moderate ROP, which usually disappear within 15 weeks, around 4 months, and they do not require treatment, and vision develops normally so long as there is no other eye problems. Okay, but 10% have severe ROP and require treatment. Okay, again, to summarize, 85% regress spontaneously. Of the 15% left, 90% of those 15% develop ROP. They usually disappear within 4 months and require no treatment, provided there are no further complications. But 10% have severe ROP and require treatment. So that gives us an idea overall of what is the aggression of ROP. Now, treatment, remember, treatment is done certain level at threshold ROP. This is a level called threshold ROP, which is defined as a stage of ROP where if it is not treated, 50% of babies would develop blindness. Okay, threshold ROP, it's called threshold, is a definition, is called the stage that if it is not treated at this level, 50% of children would develop blindness. And when do we call ROP as reaching threshold? It must obey 4 criteria, all four, not 1 or 2, all 4. What is that? That first, the zone 1 or zone 2 should be involved. Second, either 5 continuous clock hours or 8 non-continuous clock hours of fibrovascular proliferation should be present. Third, it should be stage 3 or beyond. Remember, stage 3 is elevation with fibrovascular proliferation. And fourth, should have plus disease. Remember, all 4 when you meet, we call them threshold ROP. These are various examples of ROPs which have crossed threshold. And again, to summarize, threshold ROP, all 4. Zone 1 and 2 should be involved. 5 continuous clock hours or 8 non-continuous clock hours. Stage 3 or beyond, and plus disease, this is called threshold. They should all be treated. Threshold. Of late, one pre-threshold stage should be treated also, and this is called type 1 ROP. Another disease which should be treated, apart from when you reach threshold, of course, you have to start treatment. But if you have type 1 ROP is a stage of pre-threshold. This is also aggressive and you should also be treated. So kindly remember, in type 1 ROP, you do not wait for threshold, we have to treat immediately, or you can treat the threshold if it reaches threshold, of course. And what exactly is type 1? Pre-threshold. Type 1, as I mentioned, pre-threshold is a high risk pre-threshold ROP and requires laser photocoagulation within 72 hours, following which, if not done, it may develop retinal detachment. So this is it's a high risk pre-threshold and it should be treated immediately. How do we define it? We define it as zone 1, remember the most dangerous zone, any stage with plus disease. It doesn't matter what stage it is with plus disease, or zone 1 again, stage 3 without plus disease. You may not have plus, but you should have stage 3. Or zone 2, which is stage 2 or 3 with plus disease. These are all definitions of type 1 ROP which should be treated. Type 2 ROPs are low risk pre-threshold ROPs and we don't have to treat them, we just observe and follow it up. And this definition is either zone 1, stage 1 or 2 without plus disease, and zone 2, stage 3 ROP without plus. Both of them are without plus disease, as you can see. Okay, that's why they can be followed up and observed. I don't think it's necessary for you to remember the definitions of type 1 and type 2, but I think you should know that type 1s require treatment and type 2s require observation. That should be enough for you. And what exactly, once we've diagnosed all this threshold, pre-threshold stuff, what exactly is the treatment? What do we treatment? The treatment, remember, we do laser photocoagulation. What is that? Laser photo, you see, what is the, now the funda is, laser photo done like this, usually we take a double frequency Nd:YAG laser, green laser, and we coagulate the avascular part of the retina. You see that we've coagulated the entire avascular retina. Basically, now we are trying to destroy the avascular retina, because see, it is the avascular retina which is hypoxic. It is the hypoxia which is producing neovascularization. So since we do not want further neovascularization, we will pull the retina off. So we destroy the avascular retina. So there is no avascular retina, there is no hypoxia, there is no VEGF, and there is no further neovascularization. So this is called as photocoagulation. This is the common treatment that we do. The second treatment that has recently been started is anti-VEGF drugs. Okay, you know that the entire gamut of ROP changes are because of VEGF, so we need some anti-VEGF drugs. So these are also used nowadays, and our old friends anti-VEGF drugs, which we have done quite a bit now, is bevacizumab or ranibizumab. Bevacizumab, and they are used in certain indications, which, like zone 1 ROP, remember zone 1 ROP is always dangerous because of macula and the fovea is being threatened, or zone 2 ROP is close, so we would like to give anti-VEGF, or APROP, which makes sense because remember APROP is immediate treatment required because may rapidly progress to retinal detachment. This is always an emergency. So these are the three indications where anti-VEGF drugs are being utilized nowadays. So your treatment would consist of either anti-VEGF drugs and photocoagulation. These are the basics of ROP. Can you remember them? Because these are all important questions for your examinations.